Okay, well, thank you. I'm glad to be here and talk about this. Hepatitis C treatment has been something I've done a lot of for the last about 9 years, and it's really fun. So I'm going to talk a little bit about that. I wasn't sure how much time I would have exactly, and frankly, I've done didactics for learners, residents, and fellows in the past, generally taken about 90 minutes, and even then it's hard to get through it all. So I guess my primary aim would be not necessarily for you to walk out and go prescribe treatment for somebody and feel competent in it, but really just to convince you that you should be doing this. But I will include some content on actual treatment too. So this is just some standard disclosure accreditation statements. I don't have any disclosures. Okay, so this is a question. I had a patient come in to me and say, guess what, doc? I repotted all my bonsai plants this weekend and I finally moved my couch. I haven't had energy like this in years. I mean, let me see. So a question for the audience, you don't actually have to raise your hands or answer, is what medical intervention has a remarkable effect to allow for bonsai repotting and furniture rearranging? And it's a zebra, but it's going to be on your board, so you have to remember. The answer is hepatitis C, and I really have a strong preference for calling it cure instead of treatment, only because that's what this is. This is a curative treatment. And once you have gone through it successfully, which the vast majority of patients do, you've been cured of your disease. I often say there's not much we do in medicine that we can't cure much. The only things that go away if we do nothing, like the common cold. But the things that we take care of, I'm a primary care doctor as well. We do our best to manage and keep things under control, but they're chronic diseases, and hepatitis C we can cure. So let's not forget that. And I'll give you a disclaimer. I can't guarantee that your patients will suddenly become remarkable gardeners, but I promise that treatment of hepatitis C will have a positive effect on their health nonetheless. So, and then the other thing too is just adding hepatitis C treatment to your practice as a caregiver for especially underserved and vulnerable populations will bring joy to your practice. And we're living in a tough time these days, but the practice of medicine is challenging regardless. Countless, paperwork and hoops to jump through, and long hours, and never enough time with the patients. And so it can be a downer at times. So it's always important to have something in your practice that brings you joy. And for you, it may not be hepatitis C treatment, but for me in the last many years, I have found that this was one of the most energizing projects that I was involved in. I think the patients that we take care of, and I find addiction medicine to be very similar, frankly. Maybe it's because I'm working often with similar populations, but hepatitis C is a disease that many people have lived with for years, with shame, with stigma, with being terrified that it's going to kill them, despite the fact that as a medical community, we tried to tell patients for years, like, you're fine, it's under good control, it's not a danger. And that was back when we didn't have good treatments. But now that we have good treatments, we can better recognize the morbidity and the mortality that this disease carries. And I would really consider that you add this, because it's just so fun to work with somebody over the course of a couple of months while you treat them, and then to tell them they're cured. And I promise they'll have such enthusiasm and gratitude that it makes it really fun. So, find your joy, whatever it is, and this could be it. So a real quick overview how I got into this, the basics of what you need to know. Again, I can't do due diligence in the relatively short time we have. And then a plug for the upcoming Addiction Medicine Grand Rounds, because I'm going to be speaking a little bit more about this work in November. So when I finished residency, I moved from San Francisco in February to Madison, but I've been in San Francisco for the past 13 years. And I did residency out there, family medicine. And then I started working for the Department of Public Health, and I worked at this hole in the wall in the Tenderloin, which is the very urban population or neighborhood in downtown San Francisco. And this clinic, Housing and Urban Health Clinic, was a clinic established to specifically care for the medical needs of patients who were homeless and formerly homeless living in permanent supportive housing. So we saw really high rates of complex and untreated or undertreated medical conditions, severe mental illness, substance use, and just some really tragic but also resilient stories. And when I started and got into this treatment, I did a small study doing sort of a needs assessment, and we interviewed patients talking about their understanding of hepatitis C. And one of the patients said something that was very poignant, which was, they don't treat people like me. And like me could mean like me because I don't have a place to sleep, like me because of the color of my skin, like me because I have mental illness, or I use drugs, whatever it was. But it was a common theme that basically I was seeing in all my patients who were being turned away from specialty care for their hepatitis C. And my boss kind of was a very ambitious person, and he said, "You want to take this on? I think somebody needs to do it. I don't have the energy." And I was a new, very naive resident graduate, and I said, "Sure, absolutely." So I dove in, and it was still when we were using interferon and ribavirin, which I will say was a lot harder. And in retrospect, I give some of those specialists I have a little bit more respect for why they were very cautious about their patient selection, because it was much more toxic and harder, but it's still the right thing to do. So I started treating patients back in 2012, and then sort of did so through the revolution that we have seen in hepatitis C, which is the advent of this new class of drugs called direct-acting antivirals. And so we've gone from using horribly toxic and not particularly effective medications to very simple regimens that are, a pill a day for 8 to 12 weeks with, success rates of 95 to 99%. And it was pretty amazing how it has changed. And then from there, I started working sort of at a greater systems level, and developed a program that allowed all the primary care providers in our network to consult and seek electronic consultation for treating hepatitis C, because we really found that you didn't actually ever have to see the patient. If the PCP could sort of select the right patients for treatment, which frankly is almost anybody, with some support about regimen selection and some basic recommendations about how to monitor people, they could do this all on their own, and the patient never had to leave the primary care clinic. I think you have probably all experienced too that when working with these types of populations, patients often develop a strong and singular bond with a team or a person. And it can be hard for them to then go out to other parts of the medical system, specifically specialty care. And so why sort of add that barrier to them that they have to, schlep to a specialty care practice or to the hospital and, see somebody who they, have no connection with, and, may not have the sensitivities to treating patients with substance use disorders or other conditions that we as primary care or substance use providers have. And so if you can whatever you can house within your own practice, I think is really important for this population. So why is primary care hepatitis C treatment the right thing to do? It's patient-centered. Like I said, it makes it easy for the patients and very accessible. It's efficient. When I got into this, we were dealing with tremendous bottlenecks to specialty care referrals. It's really satisfying. So again, it's kind of selfish. I like it because I think it's right because I really, really like it. Work with a nurse who said I would have retired 5 years ago, but this is really fun and it keeps me coming to work. So it's good. And the patients love it. No patients get that excited about when you tell them their blood pressure is well controlled or their diabetes is well controlled, but people really kind of go through the roof in a good way when you tell them that their viral load is undetectable and they're kind of free of disease they've lived with for so long. It's really important for vulnerable populations. It eliminates bottlenecks like I talked about. And most importantly, always, is it safe and effective? And studies have shown that it is. So there have been a lot of sort of retrospective studies in recent years since this has moved out of the world of specialty care to show that outcomes are equivalent and oftentimes, in fact, better when done with primary care, because I think the primary care providers have the same bond or have that strong bond with their patients, and they can engage them consistently and get them through the treatment. So, it's really important. I think there was a lot of there were some turf wars originally around this between specialty and primary care. And I think people now realize that, in fact, this surely can live within the realm of primary care. And I keep saying primary care. but it could be fully within substance use care as well. And many of you sort of wear dual hats, so it's important to think about that way too. And a lot of the work I did in San Francisco too was bringing this into our residential treatment programs, substance use treatment programs, and our methadone clinics. So patients could get treated in those settings too. So, I say primary care, but really I'm just meaning both primary and addiction medicine. So there's this great resource, hcvguidelines.org. It's put out and continuously updated by two large societies, which is the American Association for the Study of Liver Disease and the Infectious Disease Society of America. I say it's rare that two specialty organizations can agree on guidelines, but these two came together. I think they, decided they would agree to disagree where they need to, and they came up with singular guidelines that recommend how to treat hepatitis C. It's one of the best and most readable resources I know of, really for any disease or condition, but it's great. And they very clearly, as a class 1 level A recommendation, say that treatment is recommended for all patients. Medically, it's the right thing to do. There's cost studies showing that this is cost saving in the long run. It improves quality of life, it improves morbidity, and the sole exception would be patients who have short life expectancies due to other conditions. If treating their hepatitis C might in fact extend their life from a hepatic perspective, then it's still recommended. So essentially it's recommended for everyone. And more payers have gotten on board to accept this, but that's been also like a rapidly changing field and has varied, of course, as you can imagine, sort of state to state and payer to payer. So who's appropriate? And I think this is one of the big take homes, is deciding who is appropriate for treatment in a primary or a substance use treatment setting versus who actually needs specialty level care, like a hepatology clinic. So probably the biggest class you need to be cautious of is patients with decompensated liver failure. So cirrhosis and a history of decompensation. And I would not touch these patients. These are patients that should be sent to a hepatic specialty, a hepatologist. There are some real risks and FDA black box warnings on some of the hepatitis C drugs that should not be used with this population, specifically the class of protease inhibitors. But these people, live on a tenuous line, and while generally very well tolerated, these are the people that could potentially go into hepatic, like fulminant hepatic failure and require transplant, potentially. And so doing anything should be done in consultation. Hepatitis B co-infection is an interesting group. So there was a series of cases of patients with acute hepatitis and some unfortunate cases of failure and death a couple of years ago, and it was not a well-described group, but these ultimately were patients who had undiagnosed hepatitis B in most cases. And it was kind of thought that the hepatitis B potentially had been sort of suppressed over the years, and then when hepatitis C was treated and that became suppressed, the B flared and they had acute hepatitis while on treatment. So I always do full Hep B serologies, and if their surface antigen is positive, definitely they should be sent to whoever's going to treat that to have that under control before you then treat their hepatitis C. Other than that, the rest of them, I think I say with a caveat, because once you've become experienced in this as a primary care provider, I think you can wade into these waters safely. But if you're starting, anyone who's been previously treated with direct antivirals should be sent to specialty care, because they're probably going to need resistance testing and some more nuanced decision about treatment. Anybody with end-stage renal disease, again, we just take the kidneys really seriously, and if somebody's teetering on the edge of dialysis, I think we just proceed with great caution. However, there are regimens that can be safely used without any sort of dose adjustment or modifications in patients with low GFRs. Anyone with suspected or known hepatocellular carcinoma, and again, because their situation could complicate rapidly if they have known cancer. And hepatitis C is never there's no urgency to treating it. I wouldn't have somebody wait years and years, but if they have hepatocellular carcinoma and they can undergo ablation or whatever treatment is necessary, they should have it done first, and then they can be treated for hepatitis C. If they are pregnant, we don't have good safety data for these drugs in pregnancy. So anybody pregnant, generally we just wait. I think there have been some studies looking at treatment in pregnancy in terms of safety data, but generally we just say, again, like I said, it's not urgent, so we just wait, and women can have normal vaginal births and they can breastfeed, and then you can kind of treat them down the line. But if somebody is a woman of childbearing potential, so to speak, they're a priority for treatment, because if they became pregnant, it'd be better to have them cured before they became pregnant. And then lastly, anybody who has a history of liver transplants, which again, those are sort of tenuous people. But importantly, I didn't say anybody with active substance use, HIV infection, homelessness, or severe mental illness. These are actually the perfect people for us to treat. Maybe with the caveat of HIV. I was an HIV provider, so that's a more familiar zone to me. But there's really nothing complicated about those people's liver that necessitates specialty treatment. You just really need a good pharmacist or like pharmacy resource to make sure you're choosing the right regimen that's compatible with their antiretrovirals. But these are the perfect people to treat. And I was when I was in California, the Medicaid guidelines kept shifting over who they covered, who medications were covered for. And very early on, one of the first groups they prioritized treatment for was people who were actively injecting drugs, as a recognition that treatment is prevention for forward transmission. So I was proud of the state for understanding that. They also prioritized men who had sex with men because of sexual transmission. And I definitely had made the case for some female patients involved in sex trade with higher risk behaviors who might also be at risk for transmission. So anyways, but these are the perfect people for us to be treating. And there's nothing sort of complicated about their liver physiology that necessitates a specialist. So how do you know if they're ready? Because again, this is half the battle, is you want to choose the right patients who will be successful, because the medications themselves are really easy to take and really well tolerated. So we no longer have to really worry about pushing them into some medical complication. We just have to make sure we've picked the right patients who are going to be able to make it through. So I relative should be bolded and capitalized and italicized and everything, because this is also relative. When I started, we were a little bit more cautious, and by the end, we were really pushing the limits on who we were treating, and always with success. In the vast majority of cases. But is a patient relatively stable from a mental health, substance use, and social situation standpoint? So, they can be using, but are they able to engage with any consistency with you? And that doesn't necessarily even mean that they come to all their medical appointments, but do they perhaps have a community case manager who can be a liaison with you, who you can check in and say, how are they doing? Do you know if they're still taking their medicines? Are they feeling well? Or can help them get into appointments when they need to have appointments. So that kind of sort of speaks to the substance use and the mental health. The one sort of population with substance use that I might be more wary of is people who are actively binge drinking. So very, very heavy alcohol use, raises some concerns for acute hepatitis, which would not be ideal, to say the least, while on treatment. So that would be a population that perhaps you could work towards decreasing use before treating. But really, you need them to be a captive audience, so to speak, for 8 to 12 weeks, because treatment is either going to be 8 or 12 weeks. There's usually, you have to have labs beforehand, and then theoretically you want to do labs far out after treatment. But really, it's that 8 to 12 period where you just want to make sure they're taking their pills every day. And if they are, they're going to do really, really well. And so there's so many ways, like case managers or, other substance use partners who maybe you work with, who you can harness to help. We were doing daily observed therapy out of our methadone programs to give the pills to people who were on methadone at opiate treatment programs. So lots of ways to sort of get it done, so to speak. I would say that if somebody has impending incarceration time coming up, I would pause on that, because getting medications in jail and prison has generally been just much more complicated. And again, there's no urgency. So then, does your patient want to have treatment? I think some self-motivation is important, though I have found pretty consistently patients are very enthusiastic about this. Do they take medications? I had an interesting patient who I really came to understand had a very severe psychotic disorder and had a lot of mystical beliefs about medications, and we were treating and really couldn't figure out why his viral load was continuing to be detectable. And so if in general they have like some delusions around medications, maybe not the right patient, but that's rare. They do not have to have their other chronic diseases controlled. Some level of engagement with your healthcare system is important, but they don't have to have a great A1C. They don't have to have perfect blood pressure all the time. Those are things that, like, I think in the past people said, well, let's get your diabetes under control and then we'll treat your Hep C, but not necessary. And then again, like, do they have, some level of engagement with you and with sort of your community that you work with, who you can partner with? And then important, does your patient have an ability to understand the risks for reinfection? Patients can get reinfected and they can be retreated, but it's ideal to have them be able to understand that risk and engage around safer practices before you treat them. I've seen tremendous behavior change once people have been treated, not that they necessarily stop using substances, but that they use in safer ways and have safer practices. So it's been very interesting. The number of people too who I've been like, now that I finally cured this Hep C, I'm gonna finally quit those cigarettes. Like, I struggle to get people to quit smoking, and this has been like the best way to do it, I have found. They just feel so empowered afterwards. So what do you actually do? This is, gonna shortchange kind of the actual content, but those guidelines I was talking about, the hepcguidelines.org, they came out with two really valuable documents in the last year, and they call them their simplified treatment guidelines. One is for patients without cirrhosis, and one is for patients with compensated cirrhosis. And so they literally have this one pager that I've taken a screenshot of, and you theoretically could do it all off this one pager. I find that it's nice the first time or first couple times you're doing this to have somebody you can check in with, pick up the phone, email, and I'd be happy to be that person for any of you. Also be happy to work with you or people at your institutions to do more in-depth trainings. But to go through some of this fine print a little bit more, the real basics, and let's see, I've got just a couple more minutes, but the real basics is you want to get sort of baseline testing, which is kind of your classic CBC, comprehensive metabolic panel. You need to have a viral load, a hepatitis C viral load, to know that the patient is in fact chronically infected. Once you've gotten one of those, unless you think they're in the acute infection phase, in which case I would check it again in a couple to 6 months to make sure they don't spontaneously clear. Like if you have reason to believe they've been infected forever, you don't need to follow viral loads over time. There's no utility there. You need to have HIV testing, and I would do that more recently if they have ongoing risk factors, and then the hep serologies, like I said, and you want to vaccinate if applicable. And then for women of childbearing age, you do want to get a pregnancy test very shortly before starting so that you can identify any sort of unknown pregnancies. And then the big thing is, do they have cirrhosis? Well, if they do, then they don't really fit into the simplified guideline. But if they don't, then you can proceed. And so different ways to do this is there's a really easy calculation called the FIB-4. It takes into account age, AST, ALT, and platelets. And it's been validated to be predictive of people who don't have cirrhosis and be more likely to have cirrhosis. And it has a very strong negative predictive value if you fall within a range. And so it's just a helpful tool to sort of predict who might have cirrhosis or who you feel really confident doesn't have cirrhosis. The middle ground is not so helpful, but it's easy. You just Google FIB-4. And then any other sort of clinical diagnosis of cirrhosis, so any imaging findings, if they ever had a biopsy finding, really low platelets. Transient elastography is kind of a special type of ultrasound that looks at fibrosis. And then there's some proprietary serum tests too that are kind of similar to the FIB-4, but it's just like a test that goes to a send-off lab. So if any of those indicate cirrhosis, again, they don't sort of fall into the simplified category. You can still treat them, but just sort of for the specifics of what I'm looking at. Very importantly, these guidelines no longer require that, they don't say imaging is required. And I was not imaging probably 50% of my patients for the last couple of years, because I could sort of do a do a clinical assessment and feel confident they didn't have it. Now, there are some payers that require different things, and I think Jillian just texted too that some payers have more strict guidelines, but I'm talking about sort of what is evidence-based national guidelines. And so the reality is we sometimes do things for insurance companies, but technically imaging should not be required. And I think more and more payers have come to accept evidence-based practice and have started to let go of some of that unnecessary stuff. The other important thing is that they don't require a genotype because the regimens now are pan-genotypic or can be used for all genotypes. But again, often insurance requires it. So it's like a caveat there. Are you practicing evidence-based medicine? Are you practicing real-world practical medicine? There's 2 regimens. I'm not going to go into any details, but 2 pan-genotypic regimens that can be selected. The first one is shorter, 8 weeks, and generally much less expensive and thus preferred on formulary. But both are great options. Both are very well tolerated. Minor side effects, maybe some nausea or headaches or maybe a little fatigue, though my experience has been patients tend to feel great pretty quickly. And then you always want to just make sure there's no drug-drug interactions with anything they're currently taking. This is a resource for really excellent when it comes to this hepatitis C. And then education. This is a great opportunity to talk especially about transmission risks and reinfection. The other interesting thing about these guidelines is they no longer recommend that lab work on treatment is necessary. So theoretically, you've got your lab work before, and you don't need to do anything until 12 weeks after treatment. Just this morning, I was reading a study that came out in March in the Hepatology Journal saying that actually the simplified guidelines were not shown to be non-inferior. And in fact, patients on the simplified guidelines didn't do quite as well from a cure perspective, though they didn't think that really had anything to do with not doing labs, but rather the patient selection. And so I actually was always still doing labs on treatment, and my practice was to do a viral load 4 weeks into treatment. And it's a way to ensure that the patient is taking the medications and is adherent. And so I will say I still strongly recommend that if you have any concerns whatsoever that the patient may not be adherent. But as we now know, because of COVID, like telemedicine is a great way to do this, to check in, to do adherence stuff. And then after treatment, it's pretty straightforward. You do a hepatitis C viral load 12 weeks after. If it's undetectable, they have been cured. And if it's not undetectable, then you need to sort of really consider, like, why is that? Is it because they didn't take the medications with regularity? Did they have some baseline resistance, which exists but is very, very rare? Or is there something else going on? And so, again, like I kind of started at the beginning, this is the population who you can retreat them and you most likely will be able to cure them, but you should do so in consultation with a specialist. This is the simplified guidelines for compensated cirrhosis, and I'm not going to go through any of it. It's all online. So again, I don't expect, this was fast and furious, and I don't expect like people really come away and feel like, oh, now I'm going to do it. But I think the most important thing is that this is something that more and more people are doing outside of specialty care settings. And I think for our patients that we take care of, it's the right thing to do, and it's really fun. I would welcome working with anybody to help kind of hold your hands through early cases. Can't plug the guidelines enough in terms of just a very accessible resource. Patients with substance use disorders deserve treatment, and I didn't go into it, but there's many studies showing that they are effectively cured at the same rates as the greater population. And then I'm going to be talking in November at Grand Rounds about some of the greater elimination work I was doing in San Francisco at the city level to sort of not just do this in primary care, but like make it sort of a multi-pronged approach to try to eliminate hepatitis C as a public health threat there. So I probably don't have too much time for questions, so welcome any if anyone has any.
Great. Yeah, thanks so much, Kelly, and appreciated hearing more about your work in San Francisco. Thanks for sharing that. I wanted to few things came up in the chat. Was happy to see we have Kellene Mitchell from the DHS Hepatitis C program here, and she put up some useful pieces of information for us to know about this. And Dr. Landeck pointed this out as well. Prior authorization is no longer required in Wisconsin Medicaid for treating hepatitis C, and the sobriety restriction has also been removed. She offered up a link to educational content that you can see in the chat if you're able to view. This is basically hepatitisc.uw.edu. So, and then before throwing it out to questions, I always find this piece of history entertaining, that elastography actually was a technology used by the cheese industry to characterize the internal stiffness of different variety of cheeses. So that's where that started. So anybody have other questions or comments?
I was just going to comment. This is Jillian Landeck, and I definitely share your enthusiasm, Kelly, for treating Hep C. I'm newer at it, just really over the past year, have started treating out at my clinic in Belleville, mostly because when I started doing treatment of opioid use disorder in the first year, we found a third of our patients were testing positive for Hep C here. And when I've looked kind of at the data out there, there are pretty high rates, and especially kind of rural southern Wisconsin. And so it's kind of inspired me to start to look at also ways to prevent, and the lack of access to clean needles that we see in our community. It's kind of leading to this. But we've been lucky at UW that we've had a nice partner. Myself and Allison Miller often work with the head of hepatology, John Rice, to troubleshoot certain questions. And I'm treating my first patient who has compensated cirrhosis now, and he's been very helpful. There's also a pharmacy team that does really all of the follow-up with patients while they're on meds to make sure that they're complying, and make sure they're mailed from our specialty pharmacy. They get mailed out their pills. So that's been really helpful to have that pharmacy team involved. But yeah, thanks so much for the presentation.
Hey, thanks, Jillian. Oh, Kelly, I think you're muted. Looked like you're...
Yeah, I see the question about best practices for working with homeless populations, and I think it's one of these where you look at what you've got available. So if you have an opportunity to move them into temporary housing while they go through treatment, great. But I wouldn't hold on it. We actually would have patients, because this was an issue for most of our patients, coming into clinic once a week. So we would, because we couldn't mail them meds, typically they would deliver the medications to our clinic, and then we would give them a medi set with a week's worth of meds at a time. And I think most of these patients, they were managing other chronic diseases to some extent, and so they were able to work with that. We also, our shelters had, and every shelter is different, but some of our shelters had nurses there during business hours, or at least case management staff. And so we created partnerships with them. We had lockers at one of the shelters where patients could keep their medications while they were in the shelter and on treatment. We also were doing treatment out of our syringe exchange, and we set up a locker program there. So patients would put their lockers, and they would, whatever days they would go, they could just get what they needed, and then out of their lockers. And we had an NP going once a week to be there for sort of medical check-ins and the initial consultation and prescribing. So it kind of was like, you look at every setting you want to do it in, and you just think, okay, who's on my team? Who are my resources, and how can we get this one done? But I think frequent check-ins with patients who have more chaotic lives for whatever reason is probably the best practice there. Aren't people that would sort of turn loose for 8 weeks and say, I'll call you when we're done. And I'm not sure about an increased risk of infection and transmission in the jail. I mean, really depends on behaviors that are happening, and that depends on who's in jail. But in general, incarcerated populations have higher rates of, higher prevalence of hepatitis C. But that is often not because they're incarcerated, but it's because of other risk factors that are coexisting. That was a question Ritu had.
Yeah, okay. Great. And another quick thing that Kellene from DHS had offered up was just a reminder that CDC and the U.S. Preventive Services Task Force currently recommend universal screening for hepatitis C for individuals 18 years and older. You know, and in working with people who inject drugs, you know, I've found that the knowledge around bloodborne virus transmission with injection is pretty common, but a lot don't realize that nasal or smoke use of cocaine also confers risk for hepatitis C transmission in addition to the sexual disease transmission risk. So those are just kind of some points by way of education, educating patients around prevention as well.
I would also educate patients if they get cured. You know, let them know you've been cured. You do not have virus in your body, but educate them that you will always have a positive hepatitis C antibody test. Because I had multiple patients who would come back to me terrified because they had undergone. We had a lot of community-based HIV and Hep C testing going on, but it was always antibody-based. And so patients would come back to me and be like, "They told me I have hepatitis C," and I'm like, "What? Like, that doesn't seem possible. You were cured, and how would you get it?" And it was just because somebody told them they had an antibody again. So once they've had a positive antibody, that's going to stay positive. Like, you know, that's important for providers to know because they time and time again still get it wrong, but especially for patients because it can create a lot of undue anxiety to be told kind of like it's back when it's really not.
Right.
So any follow-up testing is with viral loads, and patients who have ongoing risk factors should be getting ongoing viral load testing with regularity.